everyone. Thank you so much, Kish, and to the organizers. What a tremendous pleasure to be here and to be part of this wonderful symposium. Um, so let's talk about some posterior fossa cysts. So here are my learning objectives, but really what I want to happen is that by the end of this talk, you are able to identify and accurately classify these are what are the top five most common cystic anomalies and abnormalities of the posterior fossa based on the distribution of the fluid space, the morphology of the cerebellum, and the location of the tela choroidea and chorioplexus. But to be able to do this, you really need to understand something about pertinent developmental anatomy. So by 18 weeks in a sagittal midline T2-weighted image, we should see a sharp vestigial point of the fourth ventricle, a defined primary fissure separating the anterior from posterior vermis, and a small tegmentovermian angle at this point less than 12 degrees, as well as a small cisterna magna less than 10 millimeters. In the coronal and axial plane, the vermis should be distinct and separate from the hemispheres, or what I call the bow tie knot or the speed bump sign. And then when you look at the vermis, there are three distinct hypointense zones that you can see. The anterior vermis up here, the neovermis, and then the inferior vermis and the chorioplexus comprise this lower signal inferiorly. Now, the chorioplexus is very important to evaluate, but because we can't always see it, you can use this surrogate marker, the tela choroidea, to help find it because it houses the chorioplexus. So where goes the chorioplexus? Goes the tela choroidea. And you can see in the axial, coronal, and sagittal planes, this tissue forming a V shape that points upwards and inwards towards the lower central cerebellar margin. The tela choroidea is a vascularized membrane that again houses and gives rise to the chorioplexus. It is located in the inferior medullary velum from the flocculus to the nodulus. And here's sort of what it looks like on a diagrammatic and imaging form, the lumpy, bumpy tissue at the end, the chorioplexus. On to some pathology. So first with arachnoid cysts. These come in two flavors, arachnoid duplication cysts, which are congenital, and the sort of secondary form, the fibrous arachnoid cysts. This diagnosis is made when you see focal mass effect within an enlarged subarachnoid space. So you can see the star denotes the arachnoid cyst. You can see that the torcular failed to descend to its normal position, and you see displacement of the falx cerebelli here and a normal cerebellum. Now, failed torcular descent is not specific for Dandy Walker, as you will see later. Anything causing mass effect in the first trimester can give you this appearance. Here's another case on ultrasound. At 24 weeks, we can see this enlarged fluid space with focal mass effect displacing the left portion of the cerebellum anteriorly and the falx towards the left. Same case on MRI, we can see anterior displacement of the cerebellum and some flattening more on the left than the right. And if you look closely in this case, when we don't always see this, but we can see this little membrane here, which is the edge of a cyst. Now, the natural history of these can be to be stable, to get smaller, or to get bigger, and so that's why we follow them. This case was lost to follow-up for a period of time, and the cyst enlarged and obstructive hydrocephalus developed. Here's another cyst in front of the brainstem displacing it posteriorly. This is in the anatomic location of the membrane of Liliquis. So this is a membrane of Liliquis arachnoid cysts. Unlike other cysts, these often stay stable over time. And despite the marked mass effect, these patients can remain asymptomatic. This was unchanged in the neonatal period, and there was no restricted diffusion, ruling out an epidermoid cyst. And here's a fibrous arachnoid cyst. Obviously, this patient had germinal matrix and intraventricular hemorrhage, and you can see these sort of loculations in the posterior fossa and this walled off tissue that can form a sort of a fibrous arachnoid cyst. Here's a cyst behind the vermis, or what we call a retrovermian cyst on ultrasound. That on T2 weighted images, these are a little bit motion degraded, but we can see this kind of cyst, which seems centered in the retrovermian region. But postnatally, you can see the sort of claw sign appearance, noting that it's arising actually from the vermis. So this is a vermian cyst rather than an arachnoid cyst, which is mimicking an arachnoid cyst. This patient actually had multiple additional brain lesions and was subject to maternal illicit drug use and brain injury. But if these occur in isolation, they are often benign. And here you can see a vermian cyst replacing the normal folium. So, fourth ventricular cyst, just to quickly review developmental anatomy, which is so important to understand what's happening here at 9 to 13 weeks. At this point in time, the hindbrain roof plate epithelium is comprised of three main structures: the anterior membranous area, the choroid plexus, and the posterior membranous area, which at 9 to 10 weeks will sort of evaginate and form this temporary Blake's pouch and should quickly perforate forming the foramen magendi and allowing free communication between the fourth ventricle and the cisterna magna. Here's the choroid plexus, here's the anterior membranous area by 10 weeks. Now, at the end of the first trimester, 12 to 13 weeks, we can see downward growth of the vermis, obliterating the anterior membranous area and leaving the choroid plexus at the lower margin of the vermis. And here it is on MRI. So with this background, let's talk about the Dandy-Walker phenotype. So historically, the Dandy-Walker malformation was considered a vermis that was hypoplastic and counterclockwise, rotated, massive enlargement of the fourth ventricle, and enlargement of the posterior fossa. But the latter two criteria have since been abandoned because these simply reflect the degree of CSF egress from the fourth ventricle or the lack thereof. And so the more revised criteria include inferior vermian hypoplasia, tegmental vermian angle elevation, a tail sign or an unpaired caudal lobule, a blunted fastigial recess, and displacement of the tila choroidea and choroid plexus infralaterally rather than up and in, sort of where it belongs. And so you can sort of place the blame on the rhombic lip. And the rhombic lip is a specialized germinal zone that populates the cerebellum with glutamatergic cells. And after it gets integrated into the vermis by 15 to 16 weeks, begins to really build that lower part of the vermis. And so when that's deficient or disrupted for whatever cause, you get this phenotype where the lower vermis is hypoplastic. You have this tail of tissue that's not integrated into the vermis, leaving the fastigial recess flat, the anterior membranous area present, and the tila choroidea displaced infralaterally. And again, we no longer care about the location of the torcular. All right, so you can think about Dandy-Walker as sort of an arrested development of sorts. Again, occurring before 15 to 16 weeks, before this germinal zone, the rhombic lip integrates into the vermis, leaving the fastigial recess blunted, and before the vermis grows down to incorporate the anterior membranous area, leaving the choroid plexus to be displaced down and out. So you should have no trouble recognizing this as a Dandy-Walker phenotype. It's a pretty straightforward case. We see inferior vermian hypoplasia, a flat fastigial recess, tegmental vermian angle elevation, this tail of tissue inferiorly, and if you look closely, this thickened, infralaterally displaced tila choroidea and choroid plexus. But what about this case? Sagittal T2-weighted images. This was called a Blake's pouch cyst, and you can see why. The height of the vermis was sort of borderline here, and we do have a fastigial recess. It looks a little blunted, but as you look down here in the parasagittal plane out laterally, there's this thickened tissue that's displaced. Same patient at 23 days old. This is displaced tila choroidea and choroid plexus, representing a Dandy-Walker phenotype. And what happened to the tail sign here? So the fourth ventricle is so big here, it's plastering the lower margin of the vermis up against the rest of the vermis. So you can't, it's very difficult to identify the tail, but it's here and you can see it stretched out underneath and with the blunting of the recess. So this is a very minor Dandy-Walker phenotype. Be careful with hemorrhage because hemorrhage is one thing that can be a pitfall when you're looking at tila choroidea location. In this case, it's not an issue, right? The vermis looks normal in size and shape, very sharp recess. The nodulus looks fine, but we do see some displacement of the tila and choroid plexus here in the axial plane. You can see kind of heading inferiorly in the cisterna magna, and there's some blood products here. So blood can push that around and cause hemorrhage. So at that point, you want to look at all your other structures. So vermian hypoplasia, I put this in the talk because you can have enlarged fluid spaces with vermian hypoplasia for two reasons. One, ex vacuo enlargement. Two, you can actually have a concurrent Blake's pouch cyst, which we often see with vermian hypoplasia, as in this case. So here's a 22-week gestation, some mild tegmental vermian angle elevation, a flat fastigial recess. There's this tissue here at the lower margin of the vermis. The question is, what is this? Is this chorioplexus or is this an unpaired caudal lobule? That's where you want to follow the tila and look, and you can see it's going upwards in the sagittal plane. Here's the coronal plane. You can follow it backwards, upwards, and in the axial plane on the gradient echo sequence, you can see the susceptibility that heads upwards, again, inwards towards the lower margin of the vermis. So this effectively excludes Andy Walker malformation when you can see the tila not infralaterally displaced to any significant degree. So we had this patient follow up to see what's happening here, and you can see indeed the tegmentovermian angle has now decreased. We can see a sharper recess. This proves that there was a Blake's pouch cyst process here that has either resolved or is resolving. But what about the vermis itself? So when you measure it, actually the height was about the third percentile and the AP diameter was less than third percentile. And here is a normal comparison at 25 weeks, and you can really visually see the difference in terms of the size and shape of the vermis. And further, if you look at the posterior vermis, at this point, the posterior vermis should be visually larger than the anterior vermis, and we're not seeing that same appearance here. So we had a patient with two things, a Blake's pouch cyst and vermian hypoplasia. Again, just to make the point that if you see the tila choroidea in near its normal location going upwards and inwards, you can virtually rule out a Dandy Walker phenotype. So just to quickly summarize, as far as we are here, at 9 weeks, we have normal evagination of the posterior membranous area, which should perforate and form the foramen Magendie. By 10 weeks, then there's downward growth of the vermis, incorporating the anterior membranous area by the end of the first trimester, leaving the chorioplexus at the lower margin of the vermis. After the rhombic lip is internalized, it will begin to preferentially grow the lower vermis, which will exceed the size of the anterior vermis by like 19 to 20 weeks. That's when that starts to happen. Of course, things can go off course early on. If you have an issue with the rhombic lip that is not internalized, leaving this flat recess, the unpaired caudal lobule, the chorioplexus to be displaced down and out. But if the event occurs later, after vermian growth down to the chorioplexus level, you can have an inferior vermian hypoplasia with a tilt process. And if it's just a problem with the posterior membranous area, a Blake's pouch cyst, and of course you can have vermian hypoplasia without tilt if the Blake's pouch goes on to resolve normally. So on to Blake's pouch cyst. So here is a nice example of a Blake's pouch cyst where you can see in this patient an elevated tegmentovermian angle and this tissue at the lower margin of the vermis, which is actually chorioplexus near its normal location, but can sometimes be displaced slightly posteriorly and slightly laterally, but not down and out like you see in a Dandy Walker malformation. So 50% of these will regress by 25 weeks. So this is why we change the cut point for the tegmentovermian angle. If the patient is less than 24 weeks, we make that 12 degrees. If they're over 24 weeks, 8 degrees. Here's another case of a Blake's pouch cyst here at 22 weeks, again, following the tila upwards and inwards in the sagittal plane. Here in the axial plane, here's the tila choroidea coming off the back of the medulla and heading upward. In the coronal plane, here it is, upwards and inwards, so consistent with Blake's pouch cyst. Same patient, postnatally, now the vermis looks completely normal. There's no tilt, and here's the normal tila choroidea. But sometimes you can have a residual tilt even after birth due to a late rupture. And in these cases, this can be sort of just like a Blake's pouch diverticulum. So there's no true cyst there. Maybe there's some residual cyst wall, but there's free flow of CSF. As you can see, this low signal coming from the fourth ventricle into the cisterna magna around the lower brainstem in the sagittal and axial planes. And so finally, an enlarged or mega cisterna magna. This is basically a diagnosis of exclusion. It requires no focal mass effect in the posterior fossa, normal cerebellum, no hydrocephalus. Sometimes you can also see abnormalities of the falx cerebelli, as in this case, which we see an elongated falx cerebelli, same patient on MRI. So the important thing here is to recognize whether this is an isolated process or if it's associated with other abnormalities. Because if it's isolated, the prognosis is good. If there are other anomalies, which can occur in up to 21%, 1/3 of those will have aneuploidy. So important to look for other abnormalities in the brain and body. And again, the falx cerebelli may be multiplied. Here's another case where we had post-hemorrhagic dilation versus fibrous arachnoid cyst change in the posterior fossa, so an enlarged cisterna magna, and you can see this patient had a prior germinal matrix hemorrhage. Okay, so finally, let's get back to these cases and solve these riddles. First case, we have an enlarged retrocerebellar fluid space with focal mass effect flattening in the left cerebellar hemisphere and rightward displacement of the falx cerebelli, arachnoid cyst. Here we have isolated enlargement of the cisterna magna, normal cerebellum, no hydrocephalus, duplication of the falx cerebelli, megacisterna magna. Vermian tilt with fairly sharp vestigial recess, tela choroidea going upwards and inwards, Blake's pouch cyst, normal cerebellum. More enlargement of the tegmentovermian angle with flattening of the vestigial recess, infralateral displacement of the choroid plexus, Dandy Walker, and finally inferior vermian hypoplasia with normal position of the tela in a vermian hypoplasia. Thank you so much. And we know that these fluid spaces are challenging, but I think we can usually distinguish these anomalies based on the size and shape of the cerebellum, the tela choroidea and choroid plexus, and the distribution of the fluid spaces. Thanks for your time.